This program is brought to you by the Forbes-featured Freedom Hub Health Plan, the alternative to overpriced and restrictive insurance. The Freedom Hub Health Plan is exactly what you need. By Frequency Medicine Associates, supporting health professionals and laypersons with safe and effective advanced telemedicine-like technology that can scan and help rebalance the root causes of stress and illness. By the Planet Lockdown film, which can be seen on the Freedom Hub's Rumble channel along with many great speakers. And by The Pavilion, a 21st century community hub that brings together many of the disruptive innovations featured by the Freedom Hub, including direct pay healthcare, farm-to-table dining, TED-like Freedom Hub talks, and more. Visit your-mp.com/pavilion solution for details. Hello, everyone. It is Wednesday, October 19th, and this is Cash Market Free Patient, or Free Market Cash Patient. I always get that confused. We have a good guest today, and let me take you to our website just to show you, for those who are new, where to get information on what's happening, who's coming up on our seminars, how to subscribe, and so on. I'll do a quick screen share here. And been a while since I've been here. I can see that. Missed a few days. So go to your-mp.com on the internet, and you'll click on our home tab here and go down to webinars. And that will take you to the page where you can see who our innovators and free thinkers are, who's coming up in our disruptive calendar. And on the left, you can see the health biz and politics with Dr. Gold today, who will be presenting. And on the right are more libertarian-minded policy, liberty, freedom talks on Thursday that are more out of the box. We get those suspended, canceled from YouTube more than anything else. Anyway, you can subscribe right here. I recommend that. That way you'll get at least the notices every week, and you can sign up to the ones you want. So with that, let me stop the share. And at the bottom, by the way, are the different platforms where you can find the posted videos: Brighteon, BitChute, YouTube, and Rumble. And okay, Charles, why don't you take it from here?
Thanks, Jim. It's a pretty good website. I think right around now is our 5-year anniversary of hosting both health leadership webinars and liberty regulatory capture webinars, is how I like to phrase the Thursday one, for 5 straight years, every single week, 2 a week, except holidays. And so we've had a lot of presenters over the years on today's topic, which is subscription-based primary care, called direct primary care. You know, Dr. Cordenoy, Rutherford, Villasees, Tinsley, Bernard, Lindley, so many. I'm probably forgetting some of our guests. And the reason we keep having them is the higher level advisors for the bigger companies are increasingly using them, the monthly subscription primary care specialists, generalists, for the bigger company plans as a real panacea. Some folks may balk at the idea of paying a doctor a fee every month, $75, $100 or more for a family, but the cost benefit analysis works, especially if you have chronic conditions, big family, big company with workers who are confused by the intimidating medical system. They are great guides as well in your panicked state when you get sick or have an accident. And we have one of those advisors on the call, George Klassen, who can attest to the value of DPCs. For that monthly fee, you're going to have unlimited visits. My cousin used a DPC, Dr. Tinsley, here in the Virginia area. He died of cancer, and the position of a monthly subscription doctor at his side and our side, as we navigated the whole cancer chaos was invaluable. And the fees include unlimited visits, a lot of online and text communication. I'll ask about this, and Jeff can discuss this, but he, in his LinkedIn, mentioned hospital visits too, being included in the visit, in the cost. I haven't heard of that before. He has a lot of testing facilities on premises for EKGs, for spirometry, skin biopsies, and all of the DPCs have this. They know where to go to get a cash, good priced, well-priced labs, imaging, and specialist consults, which is really important, where to go. That guidance is so key. He'll even do home visits. I've talked to some DPCs who won't do that, but he will for a little extra cost. And he's explicit that you should have a good insurance product for the major medical, preferably with a health savings account. And if you folks read our invitations every week, you'll see that we are sponsored by what my friend John Goodman at Forbes called one of the better combos of major medical and HSAs. We use sharing and something called a MEC that's properly structured to allow for a health savings account. And we're also big proponents of the new money doubling health matching account, which is even better for those who have definitely out-of-pocket liability coming up, or you can have all three. So get with us if you need a major medical match with a DPC. Jeff is a leader in the industry. He's a founding member of the Direct Primary Care Alliance. He's on the steering committee of the DPC Coalition. He's even founded a state chapter of the Free Market Medical Association, which is that collection of independent providers and agents trying to create the cash-based direct network market, as opposed to the cartel-dominated one with the bucas and the big hospitals. So with that, I will end. Dr. Gold, and why don't you kind of give us a state of the market and your business, and then we'll go to Q&A.
Sure. First off, thank you guys very much for having me. It is, you may not be aware, but it is a national holiday today. It is my birthday. So that's, I just want to start by wishing myself a happy birthday. And I'm glad you guys chose to spend it with me talking about this riveting topic. But I am a insurance recovered physician. We're always in recovery. But I left the major hospital system. I'm a family physician. I grew up about 20 minutes north of Boston and got away for a while and ended up coming back to practice and was employed in the system after residency for probably the first 10, 12 years of, my career. And I think from an early stage, even back in residency, I had the kind of WTF question in my brain as to what I was doing and why is this system work the way that it does or not work the way it does. And, I think for the first part of my career, getting married, starting a family, having children, moving, I did what every other primary care doctor does. You sign an employment agreement, whether it's with a private practice or a hospital-owned practice, and you have their credentialing office help fill out all your insurance contracts and Medicare and Medicaid, and you go to work and you see your patients every day like an automaton, and you start quickly realizing that the idealistic view of what you had wanted to do with your life is not what it's turning out to be very quickly. And I decided that as my people use the word burnout, I think that's kind of a softened term of what really is, in my opinion, emotional abuse and servitude. You start realizing that, you worked too damn hard and gave up too much of your life to take care of people, to keep doing what you're doing. So I knew that because of my mouth and because of my personality, I was never going to work my way up the corporate ladder with my employed job and make more money, and knew even if I could, I'd be miserable doing it. So I asked myself one night, do I either continue to complain and listen to myself complain and do nothing, or do I accept where I am and just deal with it? And I decided that I was going to stop complaining and make a move to do something different. And in the landscape up here, you know, we're the foundation of Obamacare with Romney Care. We're a very heavily insurance addicted state. You know, we do have a lot of concierge medicine up here. It's been around for a while, and I'll preface by saying I don't begrudge any physician or patient who goes that route if it's the right thing for them. The reason it wasn't right for me was I just didn't feel like it got to the root of what the actual problems are with our system.
Explain that, the
And
concierge difference.
the main difference, you know, is with concierge, you're personally paying a retainer fee for you or your family to be a member of a smaller practice, have more access to the doc, better care, better relationship. But it's still built on a fee for service insurance-based chassis where they're still billing third parties. So the reason a concierge doc can get away with 300-400 patients per panel is they have two streams of revenue coming in. They have the annual fee from the family or the patient, but they're also billing third parties per visit for annual exams, procedures, labs. And my whole theory is insurance is what the problem is, you know, using that as a form of payment rather than what it should be for is part of why the system is so screwed up. So I had never heard about direct primary care. I always give props to Dr. Josh Umber at Atlas and Wichita, Kansas, because he was the one that retweeted a tweet about DPC that was what caught my eye and had me reply all and say, what is DPC and why do I not know about it? And that was probably around 2013. And the rest is history. I researched and read and did everything I could to learn about DPC, about Obamacare, about, you know, the whole policy world and the whole system that we have and why it is the way it is. And if you asked me if I'd be interested in this 15 years ago, I probably would have laughed at you. But, you know, I think we're sitting, I know it's a grandiose statement, but I think we're sitting on the solution to the health insurance mess of this country. And, you know, you can only ignore economics 101 for so long. You know, I'm not really sure what our policymakers and public think as to why a service like healthcare does not function in the same economic principles as every other service industry that we use and have insurance for. So, you know, I went to my old employer and I brought a presentation to them and I said, is there any chance, you know, that we could pilot this with me through my old job? I didn't want to have to get a loan and pack up and move, but I knew that the chances of that happening were slim to none, but I thought it was the right thing to do. And of course it did go nowhere. But I had a patient who made a lot of money in the reinsurance industry and, you know, kind of said, look, I've made my money. I believe in what you're doing. I think the system, especially around here, needs disruption. And I'll give you a line of credit and, you know, make a simple loan note and be your angel investor. And, you know, he's like, let's go do it. So, you know, we opened up January 15. And I'm not going to sit here and say that this is easy or that it's been an easy 6-7 years of transition. It has not. I think the growth of this model and the status of it is very different depending on what region and state you go to. And this has not been an area that's been easy to do it. Being an independent DPC doc, I think I was the first that actually successfully did it. Since I've opened in Mass, I think there's about 16 to 20 more independent DPC docs that have since opened, which is great. You know, and here I am after a lot of people telling me that including some of my own family, that I would fail, that this wasn't Kansas and this wasn't going to work. And, you know, I'm 7 years in and I'm certainly financially not where I would ideally like to be, but I'm profitable and I've been paying my investor back, you know, slowly but surely. And, you know, my mission is to continue having a successful business and practice here, and eventually, you know, helping more docs get out, whether they're coming out of medical school, residency, whatever, and practice medicine the way that we were trained to. And that's my story in a nutshell.
That's great. So folks, if you have a question, just find the raise hand icon under the reactions tab around your Zoom controls. And eventually, I guess you can just blurt out your question too. George Klassen, if I could put you on the spot, let's talk about growth, which happens, from my understanding, with the large and small group market, where self-funded, especially employers, include DPC to, you know, lower out of pocket, to triage more issues for the guidance. You know, it's not an easy sell. A lot of the stuff, whether it's sharing, self-funding, DPC, direct contracting. And then maybe, Jeff, you can respond to what George says, if you don't mind, George.
100%.
Certainly, Charlie. Well, the way things have gone the last 10 years is that most employers out there that are on fully insured plans have shifted the out-of-pocket costs so much that employees are functionally uninsured, because when they access healthcare in the fee-for-service world with no transparency, they get sent these crazy bills for things that are not expensive, like blood panels that Dr. Gold does for $3 to $12. It gets billed on a insurance contracts $400 to $700. That's all subject to deductibles now, so people end up paying that when they go to the doctor, so they're functionally uninsured. As far as self-funded plans go, you know, a lot of employers out there think that they have an insurance problem because the costs keep going up and up and up before they to pay for their health insurance plan. But the fact is, the real problem is how their employees are accessing healthcare, and then how they finance that. So, for example, direct primary care, right? That's a great solution, because at a capitated rate, and we consider the DPC fees now as very reasonable for the services provided. It's very valuable. So most employees can get about 90% of their care through the DPC, which means your people aren't going into the hospital system where they rate the plan. And then the hospital system and the fee-for-service world chases the perverse incentives. So then you have over-treatments, unnecessary treatments. They basically sacrificed the doctor-patient relationship a very long time ago to make time for billing and coding. So in the regular fee-for-service world, it's not the best healthcare they can get, and the DPC provides that solution where you can actually get good value for money. And what we see on claims, our groups that run on DPC, we have a decent participation of employees engaging in DPC. There's a lot of things that don't show up in the claims pool that run through the TPA, and that's because the DPC doctors are working really hard to manage the care for those people, and they can manage chronic conditions really well. They don't send people for unnecessary testings. They don't order CAT scans and MRIs when ultrasounds and X-rays would be a better place to start. When they do send people out, they love the tools that a good plan will give them, such as steerage. Where can they get a good cash pricing, and when can we incentivize the employees to say, well, if you allow the steerage, we can waive all your cost sharing for whatever it is you need, just about most things you need. Everybody wins in that scenario. But the fee-for-service world, you can't pull that off successfully. The two things, human behavior, and then also it's just so impossible to navigate, even for an expert, which is another thing where the DPC comes in. Is like they provide advocacy, real advocacy for a person they actually know and have a relationship with. And that is extremely valuable. And a lot of people don't see that or understand that. But when the chips are really down, and an employee has a DPC doctor that will be there with them every step of the way through, as they have to navigate the healthcare system to get the care they need. This stuff can actually save lives, but I know for a fact it saves a lot of money as well. So it's kind of like, we hear it a lot. Everybody's out there, like, where's your data? Where's your data? And the response to that is, you're asking the wrong question here. There's a great saying: it's better to be approximately right than precisely wrong. If would you trust the hospital system to take care of everything your employees need, knowing what we know what they're up to, or would you put some trust in a doctor that serves the people in his community and has their best health outcomes at heart? And also he wants to take very good care of the employer as well by taking very good care of their employees. So it's kind of a symbiotic relationship if it's done right. And the groups we have that do this, they don't change the DPC piece. Sometimes they have to change their insurance for whatever reason, but they will not rip the DPC piece out, because once employees engage in that, they actually see that is where the real value is.
Jeff, there's a lot there to unpack. For one, I noticed on your LinkedIn, you include hospital visits in your monthly fee. You have online specialty consults. The advocacy piece that George mentioned, that would seem to be huge because people are panicked in a crisis, especially over the past couple of years. Talk about that for a bit. Why is George right?
Yeah, I think that, I'm a really simple guy, and I think I've always been taught that, you look for Occam's razor. When you get somebody who comes in with a multitude of different complaints or a problem that has many different things, you try to find the unifying source of the problem and fix that. And I think what's happened in healthcare is in health insurance, which, George and I always stress are two totally different things. One does not equate to the other. I think the system is really not broken. It's built exactly the way that the people in power that control the money want it to be. I can have an easier time buying a stock online than figuring out the price of a blood test. It's built this way on purpose. And when people say, we need a single payer, and there's certain aspects of that I do think are positive, I actually respond and say, we already have a single payer that allows all this crap to happen. These PBMs, the kickbacks, the lack of transparency, it's all approved and allowed by the government. But yet, if I don't say where I get a pen from, I'm an evildoer. So I think that the biggest issue with the system is the fragmentation. Everything is in these little silos instead of everybody working collaboratively together to do the right thing for the patient first and foremost, based on that individual and what their needs, what their goals, what their resources are, and then doing what's right from a financial perspective, including do no financial harm. I'm not going to make someone better physically if they can't afford the test, they can't afford the medicine, they can't afford a visit to talk to me. I can't help them. But also, really collaborating. I always say insurance and coverage is a very important part of the whole picture. And I have no problem working with an insurer to provide the right type of insurance that people need, but I'm not going to work for one. I'm going to work for the patients. And I think that patients really need to start asking the really hard questions in the mirror as to who do they want to pay and who do they want working for them. And, right now you can't sit there and get frustrated with the system when you're expecting a third party to pay for everything. You're relinquishing your control. So I think the things we do, whether it's combining online specialty care, home visits, going to the hospital, obviously where I'm not contracted with any government agency or, a third party payer, I can't actively manage my patients in the hospital. They do get admitted to the hospitalist system, which is a whole nother topic, but I go over and I make sure that the patients are getting well cared for, that the hospitalists who have a very tough job, they're getting these patients that they don't know anything about other than what's in a chart or in a computer. I do it in a way where I collaborate. I'm not there to step on anybody's toes or over, step my ground, but I've had instances where, the hospitalist in a typical case, we're going to put a patient of mine on a medication that, would be the right thing to do, but didn't know that my patient 5 years ago tried that medication and had a severe reaction to it. That's another day or two in the hospital that is saved. And if you're an employer paying that bill, which is indirectly the consumer paying the bill, those 2 days in the hospital can be a really big savings off one little simple thing. And as George said, people want data. They want data. Well, here's your data. You have a system that doesn't work. So instead of making us try to prove that what we're doing is better, how about stepping back and just saying, do what you're doing and let time tell? If employers and patients don't value what we do, and the market will decide that. That's the beauty of a free market is, let people choose the insurance or the sharing coverage or whatever it is they need that suits them and their family. Have an open marketplace. I always laugh when I hear catastrophic insurance. Talk about, a redundancy. That's what insurance is for. It's not built to be a form of payment. And unfortunately, I kind of frame this in two ways, which I've written about, over the past 6 years that I've been doing this. Is one, we kind of have a psychology Stockholm syndrome where people have been taken captive, and this is all they know. This is all they know, only place they know how to survive, even though they're not surviving. But they psychologically have to identify with their captor in order to maintain their psychological stability. The other model I bring in is addiction. What's the definition of addiction? Doesn't matter what the substance or the object is that you're addicted to, it's the behavior and the psychology around it. And when you say to a patient, you have a $3,000 deductible and I can get these 4 labs for you for $20 total, and they say to you, well, bill it through my insurance because I want it to apply to my deductible, and they'd rather pay $500 out of cash for the same lab test, that's addiction. Like people who smoke, like they know that it's bad for them. They know they're smart people, but it's the addiction. It's the psychology that goes along with that. And that's what, in my opinion, the government and the insurance companies have really built the best business model on the planet. Like they've got people to believe that without using insurance for everything in healthcare, you will go broke and you wouldn't get care otherwise. When we all know, A, that's the complete opposite of the truth. And B, it's the insurance model and the third party model that's actually making people go broke. It's not the doctors getting paid directly that's making people go broke. It's the way the system's structured. So, I actually I'm on faculty at Tufts Medical School, and I actually had a call with a physician there who runs the family medicine department this morning, because he sent out an email yesterday about getting a group of physicians in Massachusetts together to try to double down the investment in primary care in the state of Massachusetts. And he said, I was listening to him talk, and they were saying that they had to actually hire an entity that they were referred to by the Commonwealth Fund to actually do they had to pay to do a financial study on how to save money. And I literally my head was spinning. I'm like, you have to pay somebody to figure out why what we're doing isn't working, like, and pay money for that. Like, I mean, it's just, we can't get out of our own way. And that's doctors included. Like, you know, there's plenty of blame to go around. You know, it's easy to sit there and say, oh, it's the government, it's the insurance companies, blah, blah, blah. Well, my thing with everybody, and I do this with patients all the time, is look in the mirror and look at what you bring to the table, good and bad, and what your role is in this. And we're all guilty. I was guilty of it when I was employed. I couldn't even tell you how much money was taken out of my paycheck for my health insurance. That's not okay. Like, it's not acceptable to be a grown adult employed and have no idea how much money of your hard-earned work is going to an insurance company. So instead of always pushing the blame onto everybody else, my opinion is the only way we fix this problem is a bottom-up approach with everybody taking responsibility and educating themselves and finding an advocate. I wouldn't go buy a stock without talking to my trusted financial advisor. Why? I don't know what the hell I'm doing. We're expecting the lay average American to navigate this labyrinth of a purposefully labyrinthine system on their own with no stewardship. And that's not okay. We need to be their advocate. Concierge, it's gotten a bad rap because of the price associated with it. But when you look at my job as a primary care doctor, what am I supposed to do? I'm supposed to be your concierge. If I can't fix the problem, or it's out of the scope of my, you know, ability or training, what am I supposed to do? Find you the best quality, lowest cost person to help you with that problem. Whether it's a nutritionist, whether it's a physical therapist, whether it's a psychiatrist, whatever it is, that's my job. But I find people looking on Facebook groups. Who's the best spine surgeon in the area? You're asking a Facebook group? You don't have a trusted advocate that you can email and say, number one, do you even need to see a spine surgeon? Like, is this even a surgical issue, or do you just have a back spasm? So until everybody looks in the mirror and starts taking responsibility, and doctors and patients are really where it starts with, in my opinion. You know, I always say, if you look at the legal justice system and you ask people, do you think it needs reform in any aspect? Everybody would say 100% there's things that could be done better. And that second question is, would you ask a bunch of doctors to do it? No. Well, we need this system fixed, and yet we're relying on a bunch of bureaucrats and non-physicians and lawyers to figure out how to fix healthcare. Like, and we wonder why we are where we are. Rant over.
That's excellent. A couple questions from that. Think of a couple of your patients that are kind of archetypes who have really benefited from your advocacy and care. You know, the extra time you get when you're paying monthly versus fee for service, number one. Number two, talk about the referral dynamic, where in hunting for well-priced quality specialist tests, et cetera, what dynamic have you found that really connects you with quality and price, regardless of where you send your patients to? So two questions, kind of broad, open-ended questions there.
Yeah, I'll start with your last question, because I think the answer, again, is very regional depending on where you are. In Massachusetts, it's actually pretty easy to answer. It's very challenging to do that because their certificate of need laws in this state make it very challenging. When you look at imaging, the two hardest imaging studies that we have access to that are affordable, that we can get cash pricing for, are actually the two cheapest, X-ray and ultrasound. All the equipment is owned by the major hospital systems. So the radiology groups that are independent, you know, they'll do a $25 read, but you can't get a reasonable, equitable price on the two most affordable imaging modalities around. So we actually, you know, for non-acute things, we actually send people up to Derry, New Hampshire. They have a state-of-the-art, you know, imaging center up there where we can get reasonable cash pricing. We do have Shields MRI in Massachusetts, which is one of the few independent radiology centers, but they only do MRI. So we can get, cash pricing on that. But I think, this is where having a DPC doc like me, and I'm usually pretty modest, but I will toot my horn with this, is that you have to take the cost and the clinical scenario together. And the example I'll give you that answers the first question you asked is, I had a guy who is a totally non-compliant diabetic, been a longtime patient of mine. They have insurance through his wife, who's a partner in a major law firm downtown in Boston. They are on a $3,000, $6,000 deductible health plan through her employer. He comes in to me, refuses to listen to me about his diabetes. So he's, a ticking time bomb when it comes to cardiac risk, and says to me, this was years back, I just saw a segment on the news that Trump got a coronary calcium score done. I want that done. I said, are you having any symptoms of chest pain or shortness of breath with exertion? No, I just want it done. If he can get it, why can't I get it? I said, okay, well, in Derry, New Hampshire, we get them for about $200 cash. I'm more than happy to give you the order with cash pay. You can schedule, but I can tell you that your score is probably going to be out of control because of your diabetes. So no rational thought. He wants it done, blah, blah, blah. So I said, go get it done. His score comes back severely elevated, as we thought. So now my job as a clinician and his advocate is, what do I do with this piece of information that's going to be anything different than what I've told them before? So I sent the case to cardiology on our online consulting service. And I said, besides telling me to get his diabetes under control, tell me what to do with this guy based on this elevated calcium score. So we get great education from the service that says, look, this is not a score of his imminent risk of having a heart issue. This is over a 10-year period what his risk is. And I said, oh, okay. So they said, if I were you, I'd get him started on a statin if he's not on one already, and I'd get a nuclear stress test to look at what his acute risk is, if he's got any blockage or whatever. Now, mind you, he has no symptoms. So the pre-test probability of this stress test being positive is pretty low. Okay. So he says, what's it going to cost me out of pocket if I go do the nuclear stress test at the local hospital? I said, well, here's the CPT code. You can call your insurance company. It's not urgent that we get this done. So, because I guarantee you, they're not going to have this information accessible right away. Because I said, it depends on where you are in the deductible. It depends on what the negotiated rate is, blah, blah, blah. So he takes the information, and 2 weeks later gets back to me and says, it's going to be $3,200 out of pocket based on where we are in the deductible, what the negotiated rate is, blah, blah, blah. I said, okay. So do you want to go to Derry and do it for $1,200? And he says, what do you mean? I said, if you pay $1,200 cash, you can go to Derry and get it done versus $3,200 at our local hospital. He says, well, what's the likelihood you think I'm going to need further stuff done after this test? I said, honestly, I think your test probability of this being positive is pretty low. So I said, if I were you, I would go pay the $1,200. Now, if the situation were different, where he was having angina, he had a severe family history, he was a smoker, and my pre-test probability was much higher, I would have said, just go to the hospital and pay the $3,200, because you're probably going to hit your deductible this year. You're probably going to need a cath. You're probably going to need a stent, but in this case, this is where the clinical and the cost decision-making comes in to play together. You can't just say, well, because then if he goes and gets that test done for $1,200, which doesn't go towards his deductible, but then it comes back positive, and now I tell him, hey, you've got to go spend another $3,000 out of pocket when you get a cath or you get admitted to the hospital, he's not going to be too happy with me. Now, is there a small chance it could have been positive? Sure. But this is where the relationship and knowing your patients, knowing how to do your job, having the time and the ability to do your job allows people to navigate this system, both from a clinical perspective, but also a cost perspective. So that guy basically chose to go to Derry, paid the 1,200. The test was totally normal. He basically paid 2 years of care to me in one afternoon.
That's incredible. That's a big takeaway here. The cost clinical matrix, which is so critical, especially since so many folks, like George said, have been foisted into high deductible plans where they become functionally uninsured.
Right.
I always tell people in open enrollment, you may get tempted by Biden's subsidies for those premiums to leave sharing for an HMO. But you're going to have a network that's going to exclude the best doctors. And, you know, the deductibles remain at $6,000 on average. Do you have $6,000 laying around for an emergency? And then also, what about your LinkedIn statement about HSAs and insurance? You'd like folks to have an HSA for those out-of-pocket costs. Have you had experience with patients who funded their HSAs? Because I know George and his Rosetta type friends are a little skeptical on HSAs, especially for big blue collar workforces, because A, they're not funding them, or B, the employer's not funding them. So I'm not sure if you've heard of the money doubling health matching account, which we agents now are pushing more than HSAs. Actually, I push it both of them. I say HSA is a tax shelter. It's the best thing to build $100,000 for retirement. If you are sick and have out of pocket, it can wait. Double your money over 3 years in HMA for a prepaid visa. That's great for current out of pocket. What is your feeling on those accounts for out of pocket?
Okay. I'll answer that in a sec. I actually want to go back and add one more thing about the referral stuff that you mentioned. The other issue we run into in Massachusetts very commonly is when you look at the connector plans that are available on the ACA exchange in Mass, 99% of them are HMO type plans. So because I am not in any network, I cannot refer those patients insurance referral wise, not clinically, to any specialist and have the insurance pay for it because I'm not in the network. So
What?
Yes.
Is that typical?
Yes. With most HMO plans, unless you have a law in place like in Maine, where they have an any willing provider law, where an insurer cannot reject paying for a referral regardless of the patient's status, HMO, PPO, whatever. In Massachusetts, if you sign, and this is why we took an enrollment link off our website, because people were enrolling and then came in and said, oh, I see my eye doctor once a year, or, I have a chronic condition that I see a cardiologist twice a year, which they probably don't need to begin with, but, they have an established relationship with them. And if they're on an HMO plan, I cannot issue the referral to the insurance. So we ended up having, then the patient's pissed off, they leave. So we took the enrollment thing down and encourage people to come in and do a meet and greet with us first so that we can go over this with them. So what they have to do is they have to keep a listed insurance PCP in their network. If they want to see me for their day-to-day care, I'm happy to do it. And I am lucky enough that I actually have a colleague inside the system who lets my patients on HMOs just list with him. And then if I need a referral to, orthopedics or whatever, I just text him the information and he puts it through so the insurance will cover it. So that's the mess that this system creates, that patients continue and employers continue to pay into. I've actually been on the phone with these boneheads at these insurance companies, and I've said, let me ask you a question just logically. What difference does it make if you come in and you're on an HMO Blue Cross plan and you come in and you see me as your DPC doctor and you tore your ACL and I need to send you to orthopedics to get this fixed? If I send the patient to an orthopedist that's contracted with HMO Blue, what difference does it make whether I am or not?
You're going to get the money.
So it tells you this is not about money. It's all about control.
Control.
That's all it is. Because there is no reason why a licensed physician with an NPI number, with a medical license number, with a DEA number should not be able to send a patient to any specialist and have an insurance company say, well, we're not going to pay for it because your doctor isn't contracted with us. People need to see how the sausage is made. And unfortunately, when they're 3 steps removed from the transaction, it's impossible to see how the sausage is made. And that's why they keep paying into it. It's why they keep suffering and complaining. But again, they got to look in the mirror, and we're here to help them. I mean, that's my job, is I'm here to help pull them out of this. But to answer your second question on the HSA stuff, in principle, I am a firm believer in HSAs and people having more responsibility, you know, a stake in the game. But the reality is, I think without having an actual DPC physician managing, funding, and utilizing an HSA for a majority of Americans is still too much of a challenge. I think when you're weaning someone from an opiate addiction, you wean them. You don't just stop it abruptly. To say to these people, we're going to put you on a high deductible and we're going to give you this HSA, even if it's funded by the employer, and then say, hey, you know, go use it. It's still $600 in an insurance-based model that they're going to have to pay per visit, with or without labs, medications, all that. In principle, I'm a firm believer, and I hope that we eventually get there. But I think George is right on this. I've learned this kind of over the years of doing this, that if you're going to offer even DPC through an employer-sponsored plan, it's got to be just baked in. They're still used to the $10, $20 copay. They don't even, a majority of Americans are completely health insurance and healthcare illiterate. They don't even know what a deductible, coinsurance, HSA even means. So I think to take that rapid withdrawal and say, go fund this when $200 a month may be a grocery bill, or, you know, a sport bill for their kids' sports, to have them put that money aside when they're living paycheck to paycheck, I think is a pretty big ask right now. Again, I rephrase by saying I, in principle, 100% agree that people should be in control of their own money. I mean, I even think Medicaid, Medicare, I mean, I would argue that what people eat and drink is more important to their overall health and well-being than anything that I do as a primary care physician. And yet we give them EBT cards to go buy soda, to go buy white bread, buy all this crap that makes them sicker and sicker. But we can't give them a DPC card to say, or an means funded HSA account to say, here's your money, you go make choices as to who you want your care from and where you want your care from. If you're happy at a community health center, stay there. You can use this card for your scripts, whatever. Instead, we have to keep them under our control and make them feel helpless. Majority of people, if you're familiar with Erica and Garrison Bliss, they're the cousins that started Q Alliance, which was one of the first DPC practices in the country out in Seattle. This was probably back in like 2009. I spoke on a panel with her at Harvard Medical School probably about 8 years ago. And she said something that was really enlightening to me. I always thought that the Medicaid population used the ER as their primary care source because it was free. And that is part of it. You know, there's no copay, there's no out of pocket for these simple back pain, UTI, cough, you know, all the basic stuff that could easily be done in a primary care setting if they had access to it. But her point was that part of it is that it's totally impersonal. They go, they get what they need, it's a transaction, and they're gone. We're not treating them like humans. We're not giving them a relationship with a direct primary care physician or a primary care physician where they could have just texted and said, hey, this is what's going on. I'm having burning for 3 days when I urinate, frequency, you know, I think I have a UTI. Okay, fine. I know you, I know your allergies. I'll just send you in a script and treat you. Instead, they end up going to the ER because they don't have that type of relationship, because we don't treat them like humans. We treat them like cattle. And I would argue that the sicker they are and the poorer they are, the more they need this model than anybody. You know, the Medicare population, who on average, they have 3 to 4 specialists that no one even talks to each other, that they probably don't even need, with polypharmacy and overprescribing and drug interactions. You know, with Medicare, they don't even, you know, regular Medicare, you don't even need a PCP. You don't have to list a PCP. You can go wherever you want. So it's okay for them, but it's not okay for the people on HMOs to just pick and choose who their doctor is, or people that are on Medicaid plans, you know, to pick and choose who their doctor is. We can't give them taxpayer funded dollars to go make their own choices. I'm all for social programs. I took an oath to help people, and I'll take care of anybody. But the way we treat people in this system is it's just not acceptable, and it doesn't work.
Before, Jim, you ask your question, let me follow up with George, if I can take you away from a prospect. Can you build on that, where HSAs really are a tax shelter, but the DPC and the HMA is probably better for out of pocket, the health matching account?
Sure. I've had a couple of HSAs over the years. Try to do the right thing, put as much money in there as possible. I kid you not, it all went to dental. You know, HSA is great for somebody who needs another tax shelter. If you're earning 6 figures plus a year, and you have some discretionary income, and you qualify for a HSA, whether you have a MEC or a high deductible health plan, sure, go for it. You know, financial advisors, I think it was 7-8 years ago, said a couple retiring today will need about $250,000 for medical expenses. That's not going to be covered by Medicare or their insurance. That recently went up to almost 300,000 in just a couple of years. You need a lot of money set aside. So yeah, you know, when I look at employers, so if blue collar workers, generally, they might offer a HSA plan. The company might put $250, $500, $1,000 or $2,000 in the HSA for the employees. Most of these employees don't put any of their own money in there. They don't want another payroll deduction. And they've all been burned, because in fee for service, that gets destroyed very quickly. Yeah, it could be a test, you know, as Jeff was saying, you know, could be, you know, you go to a hospital for anything, it's even things that are not expensive become extremely expensive. There goes all that hard work and savings and everything. But we should still act like, you know, take some personal responsibility. I have in the past as well put money just in a credit union savings account. Then I discovered the HMA. That's what I do now. I have money set aside every month, and it's growing. And the nice thing is, it doesn't reset every year. It's just if you, it's not like a dental and a vision plan. Every year it resets. You have limited benefit. You have limited benefits. This is like, use it when you need it. When you don't use it, it grows, etc. So I find for most people that's a much better solution. And I'm so tired of these employers patting themselves on the back, saying, "Oh, we give our employees access to HSAs." Well, it doesn't mean anything if your health plan is crap. Your deductibles are so high that nobody can afford to use the plan. And when you look at the contributions, there's virtually almost none. It's only upper management that's taking advantage of that. So there's never one fix for a complex problem. But you know, people should do what's best for them. And Jeff's absolutely right. You become empowered when you give yourself more choices. So that's kind of what I would encourage. If employers are thinking that way, or people want to take better care of themselves, is look at where you get better choices. Where can you be more in control? And then put together something that works really well for you and your family, because it's different for everybody.
Thanks, George. You know, I'm thinking with Trump's ICRA, more and more larger employers are going to not self-fund, but they're going to use sharing and DPC and HMA, those 3 things. And I like your point, Jeff, about inserting DPC to the safety net. I think elderly patients and chronic patients need DPC especially. They are mistreated. Jim, go ahead.
Thank you. I don't think I'll be moving to Massachusetts.
Don't.
Yeah, wow. This question is for Jeff Gold, a businessman and a marketing expert. And I'm curious, how do we promote DPCs? What are you doing? And I see clinics down here. I'm in the DC area where they're advertising programs. Come in for we have a great weight loss program, anti-aging, diabetes, that sort of thing, rather than come and meet us and we'll take care of you. So I'm curious if you're doing any of that, or what you found success with, what you might recommend to other physicians thinking of going the DPC route to help build up practice more quickly.
Yeah. I mean, those are all, great questions. I mean, to backtrack again on the HSA thing, the one thing I wanted to add too is, as we've probably beat this discussion to a pulp, but working with a high deductible HSA plan with an employer group right now, there's a lot of controversy about whether you can even use DPC with a high deductible HSA type plan. On the personal, family, individual level, I have people use their HSA to pay our monthly fee all the time. I mean, if you look at the IRS criteria, we meet every one of them, unlike concierge, where you're just paying for access. With us, that monthly fee covers all the medical decision-making, treatment plans, visits. But, there's never been an official ruling with the IRS as to yay or nay. So some compliance teams, with an employer group, depending on what their risk tolerance is, will shy away from using DPC if they have a high deductible HSA plan in place. Others, may be more, risk willing and say, screw it, we're going to do it anyway. I've never had anyone get audited over it, but I just wanted to point that out because we warn people to just speak with their tax advisor or their accountant on the individual family basis. But as George can attest, with a lot of the employer groups, their compliance teams will say, this is too gray. We're not going to do a high deductible HSA and use DPC because not only can they not use it, but they also can't fund their HSA if they have a DPC membership. So it's a nightmare. It's just bureaucracy at its finest. To answer your question, Jim, it's pretty simple. I do my job. To sound like Bill Belichick here, I do my job. I show up. My personality may not be for everybody, and that's the beauty of being able to pick and choose who your primary care physician is and who is a good fit for you. But I think the patients that do want to be with me, I just do the best job I can to take care of them and advocate for them. And I think that is the best marketing tool that you could ever do. I don't begrudge anybody that finds, a niche market that will help them grow and keep their lights on. My business partner, she got certified in medical weight loss through Harvard Medical School's program. So she does that in addition to her DPC practice. I like it because, you're still trying to help people, metabolically and get them healthier. Some people do cosmetics and this other, anti-aging stuff. Again, it's their choice. And if there's a market for it, by all means do it. Just doesn't fit, really with my ethos and my mission. They can go to a med spa to get that stuff done. We've tossed all these ideas around. I just try to practice holistic care and go over pluses and minuses of treatment. And I think what it boils down to is, we're all patients at some point. And I think what does it boil down to? People want to be listened to, they want to feel that they're being acknowledged, that someone gives a damn. And it's pretty hard to monetize that type and invest in that type of relationship. But I think that's where the heart and humanity and art of medicine was, and that's what we need to get back to. You know, if a naturopath is helping one of my patients more than my training and my ability is, and they're not doing any harm, and they feel better, by all means, go. You know, we'll collaborate and we'll try to figure it out together, and I can learn. You know, I mean, I think the biggest thing that's changed in me as a physician is having my mind open to a lot of different things out there that the mainstream medical education and system, you know, does not allow physicians to do. And, you know, there's a lot out there that if a patient can afford it and they are getting benefit from it, even if it's placebo effect, it's a pretty powerful, placebo effect's pretty powerful, you know, and I just want my patients living their life and feeling better and being healthy and happy. And, you know, to me, if it takes a village, you know, and, you know, Charles, you mentioned chiropractic. One of my good buddies up here is a chiro I refer patients to all the time, you know, and he does a good job taking care of them and helping them feel better. And, you know, to me, there's good and bad chiros, just like there's good and bad physicians. You know, but I think what it boils down to is I think a lot of this alternative stuff is really due to people being listened to. You know, they can go and pay someone $400 and have them sit and spend an hour and a half with them and listen to what their complaints are and what their situation is, versus paying a $20 copay or a $400 bill if you have a deductible and being seen for 5-10 minutes and being shuffled around. What would you rather have? You know, you look at the doc in the boxes, the urgent care clinics. I mean, how do you begrudge them jumping on a fractured system and trying to fill a void, you know, where the system created it? I don't begrudge them. I don't think it's primary care. But I don't begrudge their business model, because they took a fractured system and said, hey, you know what? People can't get in to see their doctor. They don't get sick between, you know, 8 and 5, and we can stay open till 8 and see patients when their own office can't see them. You can't begrudge them for that. So, but how do we tie all that in to make a system that functions? I think, you know, we all have to bring our expertise and our knowledge and collaborate and listen to ideas and have, you know, an open discussion, which I know in today's world is not necessarily the easiest thing to do. But you'll learn a lot from different viewpoints and disagreement sometimes, if you do it respectfully. So that's kind of, you know, my thoughts on that. As I market by just doing the best job I can and hope that I haven't put an ad in the paper since I first opened. Nice. And the 700 patients I have are all from word of mouth and people just showing up at my door and wanting different.
Jim, what Jeff just said is music to our ears.
Yes.
Katarina Lindley, AAPS Texas president, osteopath, presented a year ago on DPC, and she said what you just said, Jeff, that the time you get with the patients necessarily opens the doctor's mind as it becomes a journey of the art of medicine, not just the science. And I was talking to Jay Keese last night at the Free Market Medical Association that, to me, the integrated future of subscription-based primary care is the future. And that's what so many of us want to insert into these plans, along with sharing for major medical and HMAs for out-of-pocket. The DPC piece is positioned to exploit the future patient, who's going to be more demanding. So thank you, Dr. Gould, for saying that. That to me is key, the holistic integrated future of primary medicine. And you're in the perfect spot to profit from that changing dynamic. Jim, I think we have time for one more question.
If it's 10 seconds, we're running over. I think we're over time.
Linda, quickly.
I have a question maybe for another presentation. about how you secure the confidentiality and the privacy of the health results of your patients, because we used to have a Google giving all the results in different places. Now we have DARPA, but behind DARPA we have ARPA-H, which is Advanced Research Project Agency for Health, and there is no possibility to have, especially with digital medicine, to have any private data for your patient, whatever he pays, whatever the system. So it's a huge question, and maybe could be topic for another presentation. I don't know.
Any quick
Very
thoughts on that?
important. Huh?
Quick
I
thoughts,
mean,
Dr.
all I will say is there is no more private place for your data when it comes to your healthcare than DPC. When you bill any government carrier or private carrier, once that code is filed, your health information is no longer just yours. So
Uh-huh.
if you want it
Okay.
private, find a private doctor that uses an EMR that, you know, the only information I release is if a patient gives me permission, or, you know, to collaborate with a specialist or something like that. But none of the information in that chart is released to any third party without patient's permission.
Okay.
And Jeff, why don't you close, leave us a thought and how folks can reach you?
Direct email is always the best way to reach me. Dr. Gold, DRGOLD @golddirectcare.com. That's the same as the website, golddirectcare.com. I'm always happy to help and answer questions. I want to see this grow. And my encouragement to you is act, not just speak. Walk with your wallet, walk with your feet, and encourage your loved ones and your friends and business colleagues to do the same. Because if not, nothing's going to change.